आज सुबह 8 बजे शेड्यूल हुआ था। एक सेकंड। Good morning and a warm welcome to all the dignitaries present here. I'm Shreya from Climate, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Karnataka chapter of IACTA, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and the Global Heart Care Foundation. And the focus of today's session is echocardiography in mitral regurgitation. So before going into the session, I would like to play the short welcome video now.
Good morning and welcome to the Sunday TE Echocardiography session. Thank you for joining us. This is being conducted under the auspice of Indian Association of Cardiothoracic Surgeons, Indian College of Anaesthesiology, International Society for Cardiac Ultrasound, Global Heart Care Foundation, and Global Intensive Care Symposium. These are the organizations which are supporting this activity. And this has been going on for the last 3 years with considerable popularity. Every Sunday, 9 to 10 a.m. in the morning, we have breakfast along with the DE section. And thank you for joining us. Today's topic is mitral valve repair, and Dr. Raman Shastri is slated to join us shortly. Till he comes down, I want to keep you engaged. And I have great pleasure to introduce you to Dr. Priyankar Sinha and Dr. Raghu, who will be the moderators for this session. And Dr. Priyankar Sinha is a very well-known valve surgeon. I have seen him doing most difficult valve repairs with successful results. And I am grateful to him for joining us. And then I would also introduce Dr. Raghu. He is extremely experienced in echocardiography and all difficult cases. We call him to interpret the echo, and I'm grateful that he's also with us today. And because I don't see Naman as it, Dr. Naman, have you joined? May I request Dr. Priyanka to say some introductory words before I share the screen?
Thank you, Dr. Muralidhar, for your kind welcome. I wish everybody a happy good morning, a good morning and a lovely session today. Echocardiography in the operating theater for valve repairs is almost like the backbone of the surgery. Without echocardiography in the operating room, you are quite paralyzed. And I think a good anesthetist or a good echocardiographer or one in both, I mean, both in one rather, is a great option and a great help for the surgeon in the theater. So we would like you to take us through, sir, or Naman, through the basic things that anybody would require to do in the theater. And thank you once again, and welcome to everybody for this lovely session.
Thank you, Dr. Priyankar. Dr. Raghu, do you want to say anything before I start? And once Dr. Naman Shastri joins, please let me know.
No, sir. We'll start, sir.
Thank you. Thank you. Can you see my screen?
Yes, sir.
Yes, we can see your screen, sir.
Thank you very much for joining. Today, we'll be discussing about mitral valve repair and what is the role of transesophageal echocardiography. In the last four decades, there has been great advancement in the management of patients with mitral valve disease. American College of Cardiology and American Heart Association have classified mitral valve repair and mitral valve replacement as class 1 recommendation and class 2A recommendation for the use of transesophageal echocardiography intraoperatively, and hence it becomes mandatory to have a transesophageal guidance when we do valve repairs. If you look at the incidence of the valve diseases as the population is aging, the incidence of heart valve disease is going to rise, and by the year 2030 in the United States, 20% of individuals above the age of 65 will have anywhere from mild to moderate to severe valvular heart disease, be it mitral or aortic valve disease. So this is a big problem. As the population ages, we have valvular heart disease becoming a prominent part of our management of cardiac surgical patients. In addition, in countries like third world countries and developing nations and countries such as us, we are no longer classified as developing nation. We are in between. So in these countries, the rheumatic heart disease and other forms of heart disease also contribute to mitral valve disease, and it becomes imperative for us to know how to deal with them when they present to us in the outpatient department, especially when they are symptomatic. Mitral valve is the name of mitral valve is derived from the word mitral, which is a cap or a sort of a headgear worn by the bishops, popes, and cardinals, which has two sections which resemble the mitral valve, and hence we call it as mitral valve. The mitral valve is composed of 5 distinct anatomic structures, namely the annulus, the leaflets, the chordae, the papillary muscle, and adjacent ventricular muscle. All these things contribute to the formation of mitral valve apparatus. It is called as mitral valve apparatus. And any problem with any one of these or more than one of these is likely to cause trouble in these in the.
Hello.
Yes.
Hello.
Yes, sir.
Am I audible?
Yeah, Dr. Naman, have you joined? Who is speaking?
Hello.
That she looks like Manan.
Naman,
sorry.
have you joined?
Yeah.
Can you hear me?
Yes, sir.
Will you be able to share the screen straight away if I on screen?
Yeah.
Will you share the screen? So I was just initiated the discussion saying
Actually,
that
I'm getting this. You cannot start the screen share while the other participant is sharing.
absolutely. Shall I? That's what I'm asking you. Shall I stop sharing?
Yeah,
Yes,
sure.
sir. I think you should stop
Yeah.
sharing.
So I was just describing the incidents and what is the importance of repairs versus replacement, because repair maintains the myocardial function and there's no need for anticoagulation to the same extent. So mitral valve repair becomes important. Dr. Naman, please share your screen. I was just trying to bridge the gap between your joining and the time scheduled from 9 o'clock onwards. You are ready?
Yeah, just a minute.
So why don't you introduce Naman in the meantime?
Can you
Good morning,
see
Naman.
screen? Can you see
No,
my
we
screen?
can't. We
No.
can't see the screen. We can't see the screen. Dr. Naman is one of the leading cardiac anesthesiologists in India. He's well known both in India and abroad for his skills in transesophageal echocardiography. He is extremely experienced in valve repairs, and hence we have requested him to join us and shed some light on this important topic, which is going to be an important uh, part of our care of patients with mitral valve disease. Mitral valve repair is preferred to replacement wherever possible because of the thing that the cardiac function is maintained better and the need for anticoagulation is much, much less. So now over to Dr. Naman Shastri.
This is okay?
Yes.
Yeah, it is fine. It is fine.
Yeah, good morning, everyone, and sorry for the delay from my side because the issue is about the Wi-Fi, which I had to go to my office to restart everything. So because the bandwidth was not proper anyway, somehow it has happened. So I'm sorry, like it's a session of mitral regurgitations, which I delivered a couple of months back as well. We are going to go through the different modalities of measurement of regurgitations, particularly in perioperative period. I hope my voice is clear and audible, and presentation is visible. So the impact of perioperative period is a lot for our practice, like because we have a time constraint, we have a lot of influence of hemodynamics under anesthesia, where we have tachycardia, hypotensions because of the anesthetic effect itself, which underestimate the regurgitations. Certain cardiac conditions like LV dysfunctions, hyperdynamic left ventricle, associated other valve regurgitations, all are contributing directly into the quantifications of regurgitations, and ultimately we have to deal with the surgeons, which ultimately lead to the better outcomes. So dealing with the surgeons in perioperative period is an art which you have to explain exactly the amount of quantifications and what is to be done. So only by quantification saying moderate MR or severe MR doesn't end the purpose. We have to exactly locate what is the problem, what is the pathology. And today we have Dr. Priyanka Sinha. He is a leading surgeon for the mitral valve repair. So he would be the best person who knows about this. Now, when we talk about the mitral valve, so mitral valve is not only about the leaflets, it is all about the mitral apparatus completely, like annulus, leaflets, cords, papillary muscles, and the left ventricle, left atrium, and annulus also. Now, the advent of 3D echocardiography has clearly nicely shown us how the annulus is looking like saddle-shaped annulus, and that's a beauty about the mitral valve. Because of that, the good coaptation surface are attained because of the shape of the mitral valve geometry. And when we talk about the mitral valve, we cannot forget to mention about Carpentier's nomenclature, which has given the anterior, like posterior mitral leaflets into the three segments because of the natural indentations from the lateral aspects to the medial aspects, which is from the P1, P2, P3, and corresponding segments of the anterior mitral leaflets are A1, A2, A3. This is area of L appendage, this is area of aorta, this is area of middle commissures, This is area of little commissures, and this is how look. So respective segments of the PML is A1, A2, A3, and P1, P2, P3. That is how we look, and this is a surgical end-phase view in this is a end-phase view on 3D echocardiography and surgical surgeon's view when they are opening up the LA. So we have to explain them exactly where the pathology lies. When we talk about 2D echocardiography, there are nearly the 7 views, and these 7 views are necessary to locate exactly the site of pathology. This is mid-esophageal 5-chamber view where we are cutting across the anterior segments of the leaflet. So we are seeing the A1, P1 segments. We go a little deep and then dip down to the esophagus. We are seeing the posterior segments, and so we are going seeing the A2, P2 segments. Now this is by increasing the axis to nearly 40 degree, and which we saw that A2 segment is sandwiching between the P1 and P3 segments, and here this is a very good view which is called as bicom view or bicommissure view, where we can see the 2 separate commissures and A2 segment sandwiching. The reason being that the posterior mitral leaflets in encircling the anterior mitral leaflets from their commissure all around. So when we are cutting across the commissures, then we are cutting the A2 part here as well as P1. As it is anterior part this side, so this comes P1. This is posterior part, so this comes P3, and this is A2 part. This is LA appendage view. We all know that, and this is the only view where we see entire anterior mitral leaflets, which is A3, A2, A1 segments. Now increasing the axis further to 120 to 140 degree, we are cutting the mid-esophageal long axis view at segments exactly like what we were seeing the A2, P2 segment in the mid-esophageal 4-chamber view. This is long axis view where we are seeing the P2 and A2 segments. This is an aorta. This is anterior part. This is right ventricle. So this is anterior part. So this is AML. This is PML, and then we are cutting at A2, P2. Now this part. This part is it's a transgastric. It's a transgastric 2-chamber view, or this view is very important view where it's a 90 degree in transgastric view. Once we put the esophagus the probe right into the gastric segments, and we flex the view, and then after flexing the view, we just pull it a little further. We see the submitral apparatus. So this is the best view to see the submitral apparatus. LA view is here, LA appendage view, and this is the horizontal view of exactly these segments, these 2 segments. Like this is a vertical view, this is a horizontal view. Same view we are increasing by 90 degree, and we are getting this same view. This is called the 2-chamber view, transgastric view, where we are seeing the submitral apparatus, and this is a deep transgastric basal short axis view, because in this view we are seeing the anterior mitral leaflet, posterior mitral leaflet as it is cutting from the base. And this is an anterior part of this image, of the heart in the image. So this is the A1, P1 segments, and this is A3, P3 segments. If you put a color, we can get to know exactly where we have regurgitations, like here it is in A2, P2. So this is very important, 7 standard views. And why we want all the views to be assessed, because we have a 2D echocardiography, and in 2D echocardiography, we need to have the exactly mental reconstruction by evaluating the different views where exactly the segments lies. So 5 mid-esophageal view and 2 transgastric view comprise of the complete assessment in 2D. But after the advent of 3D echocardiography, we can exactly know from both LA and LV aspects. Like this is, we are looking from the surgeon's view. It is end-phase view, where this is AML, this is a PML view, and this is anterior commissure, this is LA appendage, this is the 12 o'clock positions, it is aortic valve. So it is recommended that when we look at the aortic, when we look at the mitral valve, the aorta should always be at 12 o'clock positions, whether we are looking from the LV or LA aspects. And you can see the LA appendage. So this is A1, A2, A3 segments, P1, P2, P3 segments, as it is seen here. And this is from the left ventricle view. And you can see that this is A1, A2, A3, P1, P2, P3, because we are looking from the other side of the heart. So basically, 3D echocardiography has made our life more easy by exactly telling us where we are supposed to see and which is a segment of interest. Because these view can give you an idea exactly whether this is a scallop or this is perforations, or the cells are normal, or this is a cleft. Like here in this case, you can see that this is aorta, this is AML, this is PML, and you can see these part, and this part is a cleft. So these things are very important to understand, that we don't miss with the scallop, because anteromitral leaflet, they don't have a scallop. It is only with a PML. So we can say, yeah, this is a cleft, it is not a scallop. So the definition is, if you have the separation still the level of the annulus, then it is a cleft. If it is not reaching to the annulus, it is a deep scallop. So this is how 3D echocardiography helps us in understanding a mitral valve anatomy very well. So when we want to assess the mitral regurgitations, we have to have category right from that's a comprehensive assessment of regurgitations. Like we have to see that what is an anatomy, what is a pathology, how is the impact of the mitral regurgitations on the heart. Then you go for the quantification. So first, we do not have to directly go to the quantifications to see what pathology lies through the patient. Because if we go directly to straight away to the moderate MR, say severe MR, the surgeon, they don't want this. They want what is the reason of this regurgitation. So that is a priority. We have to look for the anatomy, then the color flow, quantifications, then this is the semi-quantifications, which tell you exactly mild, moderate, and severe. And this is a purely quantifications where exactly tell you how much grade of mitral regurgitation is there. And there are some supportive evidence, and these supportive evidence help us when we are in dilemma or the gray zone. So when we look at the anatomy, and pathology, mitral regurgitations has again, Carpenter's has given very nice functional classifications of different varieties, which gives an idea what is the pathology of regurgitation, whether it's a type 1, which is a normal leaflet movement, type 2 is excessive leaflet movement, and type 3 is restricted leaflet movement. Now, normal leaflet movement is normally the pathology where we call it the dilated annulus, mitral valve annulus, where the leaflets are nearly normal, not exactly in all pathologies, but maybe normal, but the movement of leaflets are normal. This is a type 2 where there is a hyperdynamic leafletic movement, that we call it in degenerative valve, like Barlow's disease or fibroelastic disease deficiency. This is a type 3 restricted movement. When the restriction is both in systolic and diastolic, this is what we call is a type 3A, because it restricts in both systolic and diastolic, and that is purely seen in rheumatic pathology. And type 3 is only systolic restrictions, where diastolic is okay. So that you usually see in ischemic mitral regurgitations. Now, before jumping to it is customary to know that what is a leaflet movement, what is normal, what is excess. Normally, the leaflet has to reach to the annulus level, and coaptation should be below the level of annulus. If your coaptation is reaching to the level of annulus, that is called the excessive leaflet movement, or it is crossing the annulus and pitching to the left atrium, then we can say that hyperdynamic leaflet movement is a type 2. Where most of the body and the coaptation is lying below the level of annulus, we can call it the restricted movements and restricted leaflet movements. So that is purely type 3. So Carpentier has given Carpentier's type 1 is like we sometimes see the left leaflet perforations is the commonest cause. Carpentier's type 2 is the mitral valve prolapse, as I said, degenerative valve disease. Type 3A is the rheumatic pathology, but all these pathology showing the regurgitation is because of the mitral leaflet issues. It's not because of anything else, but primary it is because of the leaflet issue. That is why it is known as primary mitral regurgitations. So type 1A, type 2, and type 3A are usually primary regurgitations, or we can say that secondary regurgitations means it is not a leaflet issues, but other than the leaflet issues, like suppose this is atrial MR. Now people are targeting very much into atrial MR, like patient's left atria is dilated, high LVDP, or patient has got atrial fibrillation. So in that case, annular dilatation because of the atrium, it leads to the regurgitations, and that is secondary to the AF and dilated LA. that is a Carpenter's, that falls into type 1. And non-ischemic cardiomyopathy means purely dilated left ventricle. Sometimes it is seen in aortic regurgitation, severe AR, where the LV is dilated, annulus is dilated, and the leaflet is okay. But then it is secondary. But since leaflet movement are okay, we can say that it is type 1. Rather, this is ischemic cardiomyopathy, which is secondary mitral regurgitation because it is a negative remodeling of the left ventricle. It is called the secondary mitral regurgitation. So there are the three reasons where we are seeing the primary. There are three reasons where we are calling secondary. So basically, we can divide primary MR and secondary MR, or with the Carpenter function classification, we can say type 1, type 2, type 3A, type 3B. There are other like sarcoidosis or the degenerative or or tissue issues like the amyloidosis, sarcoidosis. All these things can lead to the leaflet deformities. Sometimes the parachute mitral leaflets. All these things are primary, but we will not include all this thing here. Now, when we call is atrial mitral regurgitations, now it is really important aspect which is coming into way, which is a primary regurgitation. As I said, not the mitral itself is responsible, but here the leaflet coaptations is the reason, and that is because of, like, say for example here it is atrial fibrillations, or sometimes I have seen particularly in the OPD because I'm very fortunate to have the transthoracic echocardiography practice very routinely every single day. So we always see this high HFpEF patient, like heart failure with reserve ejection fractions. We can have the diastolic where we can have this atrial mitral regurgitations. So this is high LA pressures or reduced annular contractility because of the atrial fibrillations. We see this atrial mitral regurgitations. Now look at this. This is atrial mitral regurgitations, which is a type 1. You can see that a patient has atrial fibrillations and annulary dilated, but leaflet movement is nearly normal. Now type 1, another pathology is leaflet perforations, which you can see nicely on 3D echocardiography, which again predicts it is type 1. This is hyperdynamic leaflets because you can see this leaflet is reaching to the level of annulus. It is type 2. Type 3A, what we are saying is restricted movement in both systolic, diastolic, visually seen in the dramatic pathologies in type 3A. And type 4, type 3B is the ischemic mitral regurgitations. Now, there is also some association of HOCM, which has got also mitral regurgitations, and these mitral regurgitations is late systolic MR, or sometimes these mitral regurgitations can go up to the level of this is a late systolic, and it can go up to the level of the diastolic phase also. Sometimes in diastolic HOCM, we also see the diastolic mitral regurgitations here. So this is we see in the late systolic, and this is typical of HOCM. This is called type 4. That is Dr. Praveen Shah, who is a big authorities, father of echocardiography in mitral valve, and he has put this, and I'm fortunate to work with him many times. So he has mentioned this type 4 HOCM. So basically, we look at the degenerative ischemic and rheumatic pathologies, and then we look at the leaflets particularly, and along with the ventricle endices to differentiate whether it is a primary or secondary. So as I said, we have to differentiate the leaflet, which is prolapse, billowing, or flare. So here you can say the prolapse is usually the billowing. If we start with the billowing, usually the coaptation is below the level of mitral annulus, but the body of a leaflet lies above the level of annulus. So this is called the billowing. Here, the prolapsing segments, the tip of the AML is tip of one of the leaflets still, both the leaflets are still projecting into the left ventricle, but their entire body is into the LA, which is called the prolapse. Here, the edge of a tip of the one of the leaflet is facing towards the LA, which is called the flare. So the flare is usually in the cord ruptures. Prolapse is usually seen into degenerative valve disease, and billowing is quite common we see in the early part of mitral valve prolapse disease. Now, so these we have to differentiate whether the patient has got the prolapse or the flail, and here we can see the very nice flail segments. But it is very important to differentiate vegetations to the flail segments, but that will come later. But this is the segments, we can say that the flail segment, which is nicely seen on the 3D echocardiography. So degenerative pathology, like if you tell surgeons that patient has got degenerative mitral valve disease, your topic does not end with that. You have to exactly say which is the pathology of degenerative, whether it is a myxomatous Barlow's disease, where you have both leaflets are prolapse, bileaflet prolapse, multiple segments, nearly more than 2 to 3 segments are involved in prolapsing segments. They have the thickened myxomatous leaflets with the thickened cord. So mitral apparatus is very, very thickened, which you can see on 2D as well as 3D echocardiography, where here, when you have the thin leaflets, usually the Marlow's disease has a dilated annulus, rather in myxomatous, rather in fibroblastic deficiency disease, like FAD, what we call it, the thin leaflet, usually in the older population as compared to the myxomatous valve, they come with the leaflet ruptures because they are thin cords and they get usually the P2 cord ruptures or one segment rupture. So they are not bileaflet involvement. They are single segments or double segments involvements, unlike the myxomatous where they have the both segments involvements. Like when we see patients pre-operative, we have to see the patient in many ways, like height of a leaflet, ratio between the anterior mitral leaflets, define each segment accurately, annulus, look at the annulus, coaptation length, LLV size and other valves. So this is how you can see that this is AML height, this is PML height. CSAP distance we measure when we have the pre-operative patients, pre-repair patients, we have to see that whether in degenerative valve disease, the concavity of the coaptations to the level of basal segments, and we look the distances, the CSAP distance, we measure the LV dimensions. So basically, if the PML height is more than half of the AML height, and if CSAP distance is more than 2.5 centimeter, it suggests less than 2.5 centimeter, it suggests that chances of SAM in post-operative repair of degenerative valve disease is quite common. So when we look at the degenerative valve disease, it is very important that we measure certain parameters prior to the repair. Here, I'm not touching more of the repair because itself is a big thing, but at least quantify whether to repair or not to repair. So this is like you can see this on 3D echocardiography, these P2 segments is looking like a myxomatous valve. But rest of the segment, if you notice that they are the thin normal leaflets, whether they are the fibroelastic or Barlow's. And this is how the 3D echocardiography helps. And very important thing is, since it is 1 or 2 segments is involved, it is fibroelastic deficiency because rest of the AML is absolutely normal. And this is what it is known as a myxomatous transformation of the degenerative fibroelastic disease valve. So these valve usually comes when you have the patient coming chronically, like after a long time patient present in the OPD with a FED, then you may get these combined mixed pictures, and this is because of the fibroelastic disease. Rheumatic pathologies, usually pathology is difficult to repair unless you have the good commissaires. And this is how you can score the commissaires. If the commissure fusion is beyond the table, inner table, it is 1 plus 1. If it is not fused, it is called 0. And if your score is more than 2, you should not attempt, one should not attempt for the repair, or I would say that repair is difficult because should be repair or not to repair, it all depends upon the surgical skill. So one definition of repair not possible is not implied for all the surgeons. So here you can see that the commissure, both commissures are involved. So it is passing inner part of the table is gone beyond that. So we can say it is a 4 score. So you can see the complete commissure. So you have to do the commissurectomy to these patients. You have to do the delaminations of the leaflets. You have to separate the cords. You have to place the ring. So many things has to be done for such cases. So unless and until you have a very nice submitral apparatus, like here you have the crowding of leaflets. So these leaflets it is not only to delaminate or decalcify the leaflet by peeling off the calcium, but along with that, you have to do so much chordal separations, neocords, commissurectomy, so many things has to be done. And in our Indian scenario, it may be difficult. Like these are the most difficult one for the repair. I'm fortunate enough to work with Thoracic, who is considered the best surgeons, and also had an opportunity for a couple of times with Dr. Priyanka Sinha. So their definitions might be different than the other surgeons. So this is like submitral apparatus is very important to see when we look at the mitral valve, that whether these cords are like here, you can see that the cords are crowded or cords are congested or submitral apparatus are fused. And many of the times this Wilkins score doesn't match here in surgically because we have to score our system. There are 3-4 different systems to categorize in MS for the repair, which I will not come into play here. And ischemic mitral regurgitation, why I'm taking more time into the differentiation of regurgitation, because pathology is very important. Like here you can see that patient has got ischemic mitral regurgitation. You may have the ipsilateral direction of regurgitations. Against the patients can have a central jack. So this is asymmetric regurgitation, so this is a symmetric regurgitation. The central jet of ischemic MR, the basic definition of ischemic MR, that the patient has to have the negative remodeling of LV or wall motion anomalies. That is very important. Along with that, having a history of coronary artery disease, and patients can have patient should have the normal leaflets. These leaflets, when you have the ipsilateral regurgitation because of the infralateral aspect involvement, that is a picolateral displacement of the papillary muscle, leads to the tethering of the leaflets. That leads to the regurgitations here. That is, these valves are very nice valve to repair. Unlike the central jet, where patients have anterior MI, which has got bilateral papillary muscle distance increases, and they are the bad patient because their ventricle is bad. And so this is how you can see this. Leaflets are totally normal, though it is systemic mitral regurgitations. You can see that submitral apparatus are also normal. So this is how you can differentiate. But like in degenerative, we have evaluated preoperative the CSAP distance and AML, PML heights. In ischemic mitral regurgitations, you have to see the mitral valve annulus. This is the mitral valve annulus. This is the tenting height. So if it is more than 34 or tenting height is more than 7 millimeters, or we can see this is a coaptation length if it is less than 4. So if they have mitral annulus more than 34 millimeter or tenting height is more than 7 millimeter, or the coaptation length is less than 4 millimeters. So in spite of the gradation of regurgitation, usually these patient needs address. Now this is the base view, deep transgastric long axis view. In aorta 5-chamber view, this is the base view for measurement of the coaptation length. And this is the tenting area, and if tenting area is more than 1.7 to 2 centimeters square, it means that it is a tethered leaflet, and these leaflets has to have has to be addressed, otherwise these patients may remain into the post-operative regurgitation. There are the other reasons how we can say that the patient will do well with the only repair, or patient will repair and CABG, or patients will require only CABG, not repair. This is another way of looking at which I may not take it right away because it will be too much. Now we go next to the color flow, which is semi-quantification methods. And when we look at the color flow, and sometimes like color gain, Nyquist limit, and transducer frequency, all they have direct influences. So color gain settings, if you have the lower in the color, if you have the higher in color gain, it is advisable to have the more than 50% of color gain to get exactly the location of regurgitations. Nyquist limit, if your Nyquist limit is very less, you will have the plenty of regurgitations. If you increase a very high Nyquist limit, you have the narrow color jets. So these are directly influenced. So ideally, it should be kept around 40 to 60 centimeter per second, and that's an ideal Nyquist limit which you can set on it. And if you have a transthoracic moderate MR, usually we see the severe MR on transesophageal, because the reason being is the transducer frequency of the TA is much higher than the transthoracic. So naturally, you will have the better spatial resolution, and we can say the better. So as I say, there are a lot of influence of the hemodynamics on regurgitation assessments, LA pressure, systolic functions, LV systolic pressures, LA compliance, LA pressure, all these things have directly impact on this. Now, if you want to make a semi-quantifications method of evaluating mitral regurgitations. This is what we can call it a flow convergence. And this flow convergence is the best way which can indicate this patient has definitely more than moderate mitral regurgitation, because more the flow, more the velocity, more the volume, then only you get very nice flow convergence. So flow convergence is indirect evidence of patients a good mitral regurgitation, but it is not always possible. Like if I say here in this case, here you don't see any flow convergence, then but you got otherwise you can see this is a significant mitral regurgitation. What should be reason for this? You can see that this regurgitation we are seeing A to P2 aspects, and because we are cutting on 2D at the A to P2 means anterior aspects, that is why we don't get a flow convergence. But if you go to the 3D echocardiography, if you look at it, A3P3 aspect, usually this happens in ischemic mitral regurgitations where you have plenty of regurgitation. So on 3D echocardiography, what we used to do it, we align the regurgitations and then we get to know exactly that the same patient, you can see that very nice flow convergence is seen here and you can quantify. So 3D echocardiography helps in quantifying effective regurgitant orifice area very well, vena constrictor area very well. So 3D echocardiography plays a very important role, because if you look at the vena constrictor on 2D aspects as to 3D aspects, in 3D aspect you can see that in functional or mitral ischemic mitral regurgitation, we have parabolic long vena constrictor area, which otherwise does not, it's overestimated regurgitations. Rather, if you look at the primary mitral regurgitation, they have a very nice circular. So usually our all this semi-quantification method works very well with the primary, not always in the secondary mitral regurgitations area. This is other where techniques of slicing it. I won't go much into detail about it. And this is how we are adjusting the flow, flow convergence with the 3D echocardiography. Now, when you put a color flow M mode, and you can see the different format. Like here, you can see this is a systolic phase completely. Now you can see that there is a holosystolic MR here, like from early part of the systolic to late part of the systolic, and all the semi-quantitative methods works with the holosystolic mitral regurgitations. Unlike in the late systolic phase, which usually happen in the mitral prolapse or degenerative valve disease, and early systolic mitral regurgitations usually happens with in the cases of cardiomyopathies or sometimes in rheumatic patients. So basically, the holosystolic mitral regurgitations, when you find that, then your all semi-quantifications method will work better. Like this is how you can put a color flow battery, and this is like you can see the early part and late part. Usually this is holosystolic, but this is very nice hallmark of ischemic mitral regurgitations. And the early part, the early regurgitation is a marker of which is degenerative mitral or prolapse, or late part is usually seen in the cardiomyopathies. So this is how you can say that how it will work effectively. Now, many of the times you may see that patient has got, here you can see the regurgitation, but you do not get a regurgitation here where this regurgitation jet has gone. Like here you can see that very nice flow convergence, but it is not always seen in all the cycles. Sometimes you see here that the multiple jets are seen. So the quantification of these multiple jets, regurgitations, like PISA method, like many of the people are using the PISA method, but the volume assessments and summation of regurgitant volume, that is RV, the addition of the regurgitant volume assessment is the best way in case of the multiple jet, not the PISA. Rather, here you can see that where this regurgitation jet has gone because of the Coanda effect. Coanda effect means it is an eccentric regurgitation jet. Coanda is a historical in 1914 in the First World War. It was when the flight jet was going through it was in the First World War where the Coanda pilot was a pilot who has realized that when they are flying the jet against the wind, there is a friction of the wind which reduces the velocities. And this Coanda effect is implemented here that when the regurgitation jet is hitting this resistance, it leads to the friction that reduces the velocities and underestimate the mitral regurgitations. Now, as I said, the Nyquist limit setting is very important. This is 77 Nyquist limit is seen here. But the same mitral regurgitations, if you reduce that, you can have the good quality of the flow convergence. Usually you set between the 40 to 60 is an ideal way. Now, PISA methods, people feel that PISA method is not the best, it is cumbersome, but it is not cumbersome. What you need to see is the flow convergence. And there are three parts of flow convergence. One is mitral regurgitation jet. This is the narrowest portion is the vena contracta, and this is called the flow convergence. And the first change of the color is the place where we measure the radius. And what it is measured that usually when we are assessing the PISA methods, usually the Nyquist limit is reduced into the direction of the jet, which goes to 40 or less, so about 40 centimeter seconds we set the edges. And then if you get the radius from the vena contracta to the first color change to the yellow, and then it indicates that it is a severe mitral regurgitation irrespective of any quantifications. So this is how you can go very easily to measure the flow convergence, that if it is with a 40 centimeters square, if it is more than 7 millimeters, 7 millimeter of a radius. So this is a flow convergence. This is the narrowest portion of the vena contracta. This is a jet region. This part is called the anatomical orifice. This is called the physiological orifice, which I may not go into the previous, but I will explain how this PISA is measure. Like here, first we adjust the PISA to less than 40, 45. Then you zoom mode, just select the area of interest, adjust the PISA, and then you measure the vena contracta. If it is 6 millimeter, then this is a step 2. Then from vena contracta, the place is little change in fact. So then you can measure the, like usually, I'll just change it. So here you can see very well now. So this should be okay. So here how we can measure the vena contracta, the first change of yellow color, that distance is called the radius. And this is a place where, and fortunately in our all echo machines, we have these parameters. Once we measure, automatically it feed and give you the mitral flow and everything. So this is first stage. We adjust, first we keep it in the zoom mode, select the area of interest. Step 1, after zoom mode, reduce the velocity in a direction of regurgitation. So this is the regurgitation direction. So this Nyquist limit is required to be reduced. If it is thoracic and regurgitation jet is going towards the base of the screen, then you have to change this Nyquist limit. So this is what we have changed it, reduced from the 60 to 45. Usually should be around 40. Then we can nicely see this flow convergence. The purpose of reducing is that the velocities of this has to be less than the velocity of RBC, then only you can get the nice flow convergence. So then here you can see the vena contracta. From here, the first color change, what you can see is a radius, and this is step 2, is the vena contracta. Step 3 is then measure the radius, and this is how you can measure this. After these 3 steps, your job is done. So this is anatomical opening, and this is the physiological orifice of the vena contracta. Now let's calculate it. Now here you have the radius, which was like you can see the tip flow. If your first step is to measure the flow, that is area multiplied by velocities. You know that velocity Nyquist limit we have adjusted 45. We have adjusted the radius. The radius what we have measured was 1.2. Like you can see this radius we have measured 1.2 centimeters, and 2 pi, you know, it is 3.14 multiplied by 2 is this. Then ultimately what we get, the flow. The first step we get is the flow of mitral regurgitations, that comes to the 407 centimeter cube per second. Once we get it, then the second step comes is the effective regurgitant orifice. Once we get the flow, then divided by peak velocities of the mitral regurgitations. Now here we can see that, here we can see the peak velocities is about 540 centimeter per second. So then 407 divided by 540, that comes 0.75 centimeters squared. So this is simple way of measurement of ERO. So once we put all the parameters automatically detected by the echo machines divided by peak velocities, then you get effective regurgitation orifice area. So ERO, that indicates many more things about this. Now, if our releasing velocities is 40 and if our peak velocities is 500, then simple way of measurement of ERO is R square by 2. So in this case, you can see that it was radius was 1.2. So 1.2 raised to 2, it is and divided by 2, you will see that it is 1.4. R square is around 1.4, and divided by 2, it comes to 0.7. So we can know exactly what is effective regurgitant orifice area. So again, radius was 1.2 centimeter. That square you get it about 1.4 and all something, and then divided by 2, that comes 0.75 centimeters. So this is how you can measure the effective regurgitation orifice area. Once we have VRO, then you just trace this regurgitant jet, that will call this TVI, and then multiply by with that the 0.75 multiplied by the TVI. What is here is 164 centimeter, and that comes to the volume of regurgitation, that is about 123. Since it is a volume, it is centimeter cube, and this is what we get the regurgitant volume. Now remember that, and that is very important, that if you have this density of regurgitations, if you have patients early MR or late systolic MR, you have to do the VTI of that portion only, not from end-to-end systolic phase, only the later or early part where you have the very nice VTI. So otherwise you will overestimate or underestimate regurgitation. This is how you measure the PISA methods. So this was the PISA methods, and now these are the issues with the PISA methods. Now we'll go to the now PISA method. I will sum up what is an issue. I tell you, usually it is useful in every place except multiple regurgitant jet and incorrect radial measurement, or we can say that very eccentric jet. Otherwise, usually PISA works for all. If patient has got multiple small regurgitation jet, what you can do is you can sum up the two major jets, flow convergence. Then also it is work, but you have to neglect the small jets. Then only it is possible. Now, this is a quantifications method, different methods like flow area, and I will just do it a little faster to this because these usually we don't do it quite often unless there are multiple jets, but we are not doing this very routinely. So we know that this is the mitral valve stroke volume, and this is left ventricle outflow volume, and this is regurgitation jet. Now, when we say mitral valve stroke volume is equal to alveolar outflow tract plus MR volume, naturally, whatever the amount comes from LA to LV is equal to the whatever the amount goes out of the aorta and out of the LA. So this is what we know. So now what we want MR volume. So MR volume is equal to whatever the stroke volume we get from the mitral valve minus whatever the stroke volume goes out of the left ventricle. So if you know the stroke volume of this minus stroke volume of this, then we can know exactly what is regurgitant volume. So once we get the regurgitant volume, then we are back divided by MRTBI, that we get the regurgitant orifice. Because if you remember that if you multiply ERO to the mitral regurgitations TVI that was exactly like MR volume in our previous PISA methods. On same definitions, same equations we are going here. But believe me, once you have regurgitant volume or effective orifice area, these two parameters are enough to quantify everything. So this is how we are calculating the same patients. Like this is LVOT stroke volume. And this is how we are measuring hemodynamics. This is a mitral valve stroke volume. This is in end diastolic phase, maximum annulus. And this is how we are getting the MV stroke volume. And then we are getting the MR volume straight away. So this is how we are measuring. Now, why we are measuring multiple modalities? The reason being is it is very easy to grade mitral regurgitation grade 1 and grade 4. But there is a gray zone where it is a moderate regurgitation. And these moderate regurgitations, when they come to the operation theaters, they become moderate to mild or severe to moderate. So exactly categorize, you have to look at the anatomy, pathology, and grading like this. So these are the grades which is all easily available in our all textbooks and our guidelines. So it is better in a gray area. We have to go through this grade 2 for this part, that if regurgitant volume is 30 to 40 ml, or just remember 3 to 4, it is grade 2, and 4 to 5 or 4 to 6. So 3 to 4 grade 2, 4 to 6 grade 3. Like this, you just remember. So regurgitant volume 30 to 40 ml, regurgitant fractions that is 30 to 39, or the effective regurgitation area is 3. So basically, anything is about 3 is grade 2. Effective regurgitant orifice area of 0.3, regurgitant volume of 30 ml, and fraction is 30%. So it is grade 2, it is moderate regurgitation. But if you have anything to with the 4, that is the effective regurgitant orifice area of 0.4 centimeters, volume of more than 40 ml, or regurgitation fraction is more than 40%, then they are grade 3 if you categorize grade 4. So moderate, these are grade 3, grade 4 should be considered intraoperatively severe mitral regurgitations. Grade 2 MR all depends upon the hemodynamic data and the pathologies. And grade 1 MR, usually they don't need to be treated. So grade 2 means, remember, number 3 digits. Grade 2, remember 3 digits. Grade 3, remember 4 number digits. So these will differentiate everything. As I won't go into detail because this is all available into the guidelines. So this is what I was talking about. Mild MR and severe MR is not a big thing. Whenever we are grading the mitral regurgitations, we always keep our Nyquist limit to about 40 centimeter per second. And whenever we have the PISA radius, as I said, which was 1.2 centimeter in our case, if it is anything beyond millimeter, consider that in intraoperatively it is a significant mitral regurgitations. If it is in between these two, then only we need to quantify. Otherwise, this area. Now, another thing is usually we don't look at the inflow velocities E and A intraoperatively in mitral valve, but in transthoracic preoperatively, if the E velocities is more than 2, or if it is more than double of the AML, atrial, then we should consider that this is a significant MR. So if A velocities is beyond 2 meter per second, we consider that this is a significant regurgitation. So these are all this is all flow convergence radius plays a major role in decisions making. Many of the times we are still in a gray zone area, but there are supportive evidence. Like here, the pulmonary venous flow, like if you put a pulse wave Doppler at the base of this is a this is LA appendage, you can see this. This is a pulmonary vein flow. You put a pulse wave Doppler here. You can put a pulse wave Doppler here, and then you can see the flow reversal. So usually there is a systolic and diastolic. There are 4 different grades. In the first and second grade, the systolic phase of the pulmonary venous flow velocity is Doppler is usually never less than diastolic. If it is less than diastolic, we should consider patient has got significant regurgitation intraoperatively. And if it is a flow reversal, like systolic flow go our other way around because of the regurgitation jet going into pulmonary vein, it is a systolic. Like here you can see that in this case, you can see there's some color flow jet which is coming back into the regurgitation, and you are getting the flow reversal here, which indicates the systolic, significant systolic mitral regurgitation. Second thing is supportive evidence is like density of regurgitation jet. If it is pan-systolic, holosystolic, complete density of regurgitation jet, we can consider it as severe. Now, whether I don't know whether should I discuss this management of primary MR on basis of this or not, but this usually we discuss in case of the repair or replacement or the clip when we talk about the clip. So in this case, primary regurgitation says like usually when we talk about primary regurgitations, and if they have the more than, I'll just do the conclusion that in primary mitral regurgitations like type 1, type 2, and type 3A categories, if patient has got symptoms or patient has got the systolic dysfunction, these patients should be subjected for the valve repair or the replacement. Repair at the centers where the repair is usually procedures, then otherwise it should be replaced. So this is what there's a primary pathology, symptomatic regurgitations, LV functions is little less, dilated left ventricle, and if repair is possible with experience, and repair can be done in advance when patient comes in early stage. Otherwise, the replacement can be planned. But if primary regurgitations, particularly degenerative A2P2 central segments, patient has got high risk of the surgery, then the TEER procedure, that is the transcatheter H2H repair procedure, is preferable on this. 15 days back only I had my talk on the planning of TEER therapies for the clip. I have circulated this, I don't know if people have gone through it or not, but when patient has got LV dysfunctions with not significantly elevated PA pressures, LV and systolic diameter less than 70 or PA pressure not more than 70, and if surgery is prohibitive risk, then TEER therapies. Otherwise, in primary patients, primary repair, earlier patients should be referred for the repair, otherwise the surgery. But if patient has got normal functions and just look at the systolic stage, if patient has got not dilated left ventricle, but pathology says it is degenerative MR and the rate of LV increasing is going above at every OPD follow, then they should be subjected for MV repair irrespective of the size. Like it should not be necessary that more than 40 millimeter and systolic diameter. But if it is less than that, but size is gradually increasing and degenerative pathology that needs repair, then should be subjected for the repair. But if patient has a severe symptomatic MR, then MVR should be subjected, MV repair should be subjected. Same in secondary mitral regurgitation. If it is, as I said, it is severe, if LV function is okay, then send the patient for after optimized medical therapies. MV surgery is always preferable. In secondary mitral regurgitations, the first and foremost criteria is to GDMT, goal directed medical therapy, which is very important, which is should be referred for usually all patient who is subjected for secondary mitral regurgitation, because 15 to 20% patients, they may not require mitral valve procedures in associated CVGs. Transcatheter H2H repair, this is a favorable anatomy or A2P2 repair, or LV function is not very depressed, then we can subject them for H2H therapy. These are the conditions where we can send this patient for the MR for the MRI for quantification of regurgitations. Like there are the very multiple jet, the MR quantification is not matching with the symptoms, or the cardiac size and function is not matching with the MR grade, and we have to associate the viability of myocardium, then they should be subjected for mitral regurgitation. So conclude, preoperative influencing factors should be considered like anesthesia, hemodynamics, pathology of MR is very important, and the flow convergence plays an important role in this, because that gives completely detail if you cannot go in depth about the quantification, because this is very important semi-quantification tool. and communicating with the surgeon in his language is important. That what is the cord, how is the leaflet, how is the pathology, what is the annulus, what they are supposed to do. This is what is the right way of discussion. Thank you very much, and sorry for the delay.
What a wonderful lecture, Naman. Can you hear me?
Yes, yes, we can hear you. We can hear you. Because we started late and this is an important subject, we can have any interaction for the next 10 minutes. After that, I
Okay.
think we need to close. For the next 10 minutes,
Yeah.
we can have any opinions, questions expressed. Thank you so
I
much.
have one question for Naman, sir. Can I put it
Yeah,
across?
absolutely. Yes, please, please.
Naman,
Yeah.
your knowledge never fails to. I've heard you so many times, but your knowledge just bowls me over every time. Can I ask you? Can I ask you to elaborate for everybody? You know, when we are discussing this fibroelastic dysplasia or myxomatous or degenerative heart disease, the SAM always comes up, and on table there is always a panic. Could you elaborate a little more? You did touch it when you were discussing the parameters. So, can you elaborate a little bit on that for the benefit of the listeners, please?
Yeah. So basically, in case of the degenerative heart disease, we have seen quite common usually in the myxomatous valve. Now, in my own experience, what I say that the C-separate distance is not the best parameters to measuring myxomatous valve, because usually our leaflet cooperation is well above the leaflets. So if you measure the C-sap distance will be always higher than 2.5 centimeters. So that is not a criteria for the myxomatous, that is a criteria for the fibroelastic disease. But in myxomatous, the important criteria is the annulus as well as the PML and AML heights. So if the PML and AML height is equal, and if the annulus is not more than, let's say, 34, 35, where you are going to put a smaller size of the ring, then the chances of the SAM is very high. Now, we have always seen that post-operative many times in particularly the myxomatous valve, when we come off a bypass, we have seen the regurgitation, we have seen the gradient across the LVOT, and not only that, on 3D echocardiography, we nicely see that coaptations just floating into the LVOT. So in that case, as usual, we just cut down the inotropes, give the volume, give the beta blockers, stabilize the hemodynamics, and then we just evaluate again. But I always have a question that if we are medically optimize the patient, pharmacological interventions we do it, but what happens if these patients comes in a post-operative with a fever, with a tachycardia, with a diarrhea, with a hypovolemic shock? This patient has got all chances of getting into the SAM in that particular time. So when I have the gradient of whenever we talk about the SAM, it is always a peak gradient. So whenever the peak gradient is more than 40 millimeter of mercury, irrespective of the patient stabilized medically or not stabilized, I would request surgeons to go back and to put a bigger size of the ring, or if they can do something with the leaflets, or sometimes they cut the leaflet, they cut some segments of the leaflet, or they add additional cords, or they increases the size of the ring. So that's what I discuss with them, because on the coming of bypass, I will show them all the 3D images and show them that this image suggests that this is definitely organic SAM. And in spite of I do pharmacological intervention, he may settle, but in post-operative while in extubation, they may again redevelop the SAM, or in the follow-up. So more than 40 peak gradients, I request surgeon that if you can consider something to go back and do something with the SAM.
Yeah, thank you so much. Can I ask you another stupid question for echocardiography? As a surgeon, when do you use a pulsed wave Doppler and when do you use a continuous wave Doppler for the
See,
MR?
yeah,
You did say that in your assessment list.
So it is a very simple thing. When you have the velocities, what you are assessing the velocities, if it is less than 2 meters per second, then you should use the pulse wave Doppler. When you have the high velocity jets, like mitral regurgitation, tricuspid regurgitations, then you should be using the continuous wave. That is number one. Like what, and you want to use a particular at one point velocities like LVOT. LVOT is LVOT, you want to measure that. If you measure continuous velocities, then it will measure the gradient across the whole pathway. But if you want to locate, like suppose RVOT or pulse or LVOT, then you use a pulse wave Doppler, because pulse wave Doppler will measure the velocity at particular point. So high velocities, all more than 2 meters, it is a continuous velocity, CW, and for the low velocities, it is a pulse wave Doppler.
Thank you so much.
That's right. That's right. Raghu, you want to comment anything?
Sir, good morning, sir. Naman, sir.
Good
You
morning.
told the mixometers well. When we think the SAM is there, we again go back, we try to resect the PML, or we try to do application of the AML. With doing all these things, still SAM is there. Can we do posterior annuloplasty?
See, usually when we have the SAM, like we are talking about after coming of bypass or pre-bypass.
After coming off bypass.
So, like after coming of bypass, you are seeing the patient having a SAM, right? Right?
Yeah. Yes.
So 2-3 things we need to see. One is with the SAM, how is the associated mitral regurgitations? Because if patient has got associated mitral regurgitations, you should not go for the pharmacological intervention that indicates that patient has got significant SAM. Means you cannot manage this patient with the pharmacological interventions. Now, if patient has got not significant SAM, number 2, you look at the gradient. If it is very high gradient, more than 40, then also I would say that straight away go and do some surgical interventions. Now, in surgical interventions, there are 2-3 things what they do. One, if they say that they cannot do anything more with the leaflets or anything with the cords, then what they do is they just go and put the bigger size of the ring. Now we have 34 maximum, sometimes 36 size of the ring is available. Now imagine if the AML height is more than 28, PML height is more than 20, 26, 24, then even though you put a 36 size of the annulus or 34 size of the annulus ring, you are not going to accommodate that cooperation margin well into the alveoli. It tends to go back into the alveoli, into the less systolic phase. So if the ML and PML is so much bulky, then if it is going beyond the 36 size, you don't have any options, then they sometimes do the resection of the AML and PML. Now your question is posterior annuloplasty ring or sliding plasty for these things. Usually it all depends upon the surgeons, their own choice. Usually what we, many times we have seen surgeon doing is addition of the cords to take it more towards the left ventricle, which can prevent it to move into the alveoli. So neocords application is sometimes is quite commonly we have seen done in this SAM patients. But resection is, and I honestly tell you, when you are not very much sure, best is to go with the mitral replacements rather than struggling more with this if you are so much in complexity.
Okay. Thank you, sir. And one more thing I wanted to ask, after MV repair, can we use M mode for an additional assessment, whether MR is coming early systolic or late systolic in post MV repair cases? Can we add M mode as one of the entity to locate whether MR is severe or mild to moderate?
See, I will tell you, when we talk about evaluation of the repair, we are making whether it is a primary MR or secondary MR into the primary MR, because now the pathology is organic, right? Because now we have fixed the leaflets, we have fixed the annulus, we have fixed the cords after the repair. So now there are less chances that you are any mobilizing, you can do anything much more with the hemodynamics very well. So yes, primary mitral regurgitations with the color flow MR is the best way of telling you exactly which part of the MR is there. But that will not contribute us in the decision making whether we want to repair, we want to go on bypass, or we want to do something extra. Because usually these patients will have the early part of MR because it's an organic pathology. As soon as blood comes to the left to the mitral valve, that segment which is not repaired properly will always throw the MR jets. and these jets are always eccentric. Usually, the residual MR jet immediately after coming bypass, you get eccentric MR. So color flow jet will not tell you to take a call whether you want to go back and do something or you just accept it or find out the pathology. In that case, I think 2D or best is a 3D echocardiography from AMR highest PML side that tells you exactly what is the pathology. Basically, what we do in 3D aspects, if we have multiplanar reconstructions in the Philips machines or the flexi slice into the G machines, we just locate that area, do the 3D echocardiography and see all around to find out which is the pathology for causing these regurgitations. But color mode can be done, but that in my practice, I have not seen it is useful or I have not used it to take a call further actually.
Okay. Okay, sir. Thank you.
Thank you, Dr. Naman Shastri, for that excellent talk. We have exceeded time limits and I think it's time to close. Before that, I would like to thank Dr. Priyankar Sinha for being with us and Dr. Raghu for his presence again and all the others who have been in the webinar. I'd like to thank Dr. Naman Shastri. Before we conclude, Priyanka, do you want to say any concluding comments? Anything you would like to say?
No, he has outlined it very well. And I think one of the most important outlining that he has done is communication with the surgeon. You know, it's hard to tell somebody your repair is crap. Redo it. But I think, Naman, you handled it beautifully. Wonderful talk. Congratulations to you again.
Thank you. Thank you, Dr. Priyanka. Thank you, Naman. Thank you, Raghu. And I think Shreyasi, can you play the last video and then we'll come to
Yes,
it.
yes, sure, sir. Sure.
This is about the announcement of the TE
Thank you,
workshop,
sir.
which is on August. Please join us.
So with all your permission, I'm playing the video.
Thank you. See you next week. Good luck. Have a great Sunday.
Thank you for kind invitation, sir.